Hello, everyone. I'm Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and this is EP Talk. And my co-host here, JD Landon, and my special guest, Zack Shinar, from San Diego, who is famous, if you will, if I could say that, or let's say he's known for. It may not be famous, but he is known for introducing and promoting ECMO in the ED. And we've been talking about that, about how that occurred and its application and that sort of thing. And I'm actually gonna let JD do most of the interrogation here of our special guest, because JD's the ultrasound guru in his shop, and so and this is an important marriage of two skills: ultrasound and CPR.
Awesome, Zack. Thanks so much for coming back. Super excited to have you. I have to talk good stuff about Zack a couple minutes here because we're going to put links into the show notes here. So if you guys are interested in ED ECMO, ECPR, you got to follow and go back and listen literally to all of Zack's podcasts on ED ECMO. We'll put a link there. And then also just recently this last year I got my pamphlet still. Reanimate. Was there for Reanimate 8. Finally, we got the go ahead after COVID, slowed everything down. And Zack, it was a phenomenal conference. We had such a good time, met phenomenal people. Jason Bartos was there, which was just unbelievably epic to get to literally just hear his experience and everything they're doing up there. And then more importantly, I told you I was going to prop your stuff. This book, if you're interested in resuscitative ECMO, ECPR, is an essential, not an option to not read this book. Everything that we're going to talk about here today is in here, and it's incredible details. Zack Shinar, Jenelle, Badulak, super exciting stuff. Zack, that's got to be like getting this book out and getting all that information out in one place for people. It's got to be a huge accomplishment. You got to feel pretty good about that.
It was a great thing. And, it's the work of so many different people. I got to organize and call the people I wanted to write each chapter, which was very special. And everybody said yes. That's the greatest thing, is that all the people that I wanted said yes. So, and Jenelle is just phenomenal. Jenelle is so great. So it was a big effort, and I do agree. I think it's a nice resource, and it really tells you a lot of things about functionally how to do to ECMO in the ER, or actually pretty much any resuscitative ECMO is in there.
Yeah, no, it's particularly a great read because I think it's overview enough that anybody could just jump in and read it, but it's also like detailed and meaty enough that you really could use it to sort of inform protocol, start putting together. It's what I'm basically using directly to try to get our shop going. And so had to talk that up. So today we want to jump into sort of an overview, but a little bit of detail, looking at almost like an ECPR primer, if you will. I think there's a lot of people that listen to EP Talk who are like, what is this thing? We're putting cannulas where this pump? Who's this pump? Like, am I credentialed? Am I certified? Can I even do this? And so I'd love to just run through a quick sort of overview with you, Zack, to talk about first. We talked a little bit about this before, but kind of what is the procedure, the idea? What are we actually trying to accomplish is really the most important initial question. And then sort of we'll jump into some of the details of like, who, some of the tricky questions of, who are good candidates for this? What is the data so far to kind of push us towards doing this procedure? So if you don't mind, run us through kind of in your, 30,000 foot view, what is ECPR? What are we trying to accomplish?
So ECPR, and we want to distinguish kind of some of these terms. So there's the term ECMO, there's the term resuscitative ECMO, there's the term ECLS, and then ECPR, and there's just a whole bunch of acronyms that you can get lost in the milieu of it all. So let's just say ECMO is this idea of putting cannulas in and running a pump that can provide oxygenation, ventilation, and on occasion, perfusion, so increased pressure. And those three things are done in different ways. So if you put both the cannulas on the venous side, then you can augment ventilation and oxygenation. If you put one of those cannulas on the arterial side, then you have the additional benefit of adding perfusion. So you can take someone who has respiratory distress with just putting cannulas in on the same side and helping them. You can put someone that has cardiac problems or perfusion problems, blood pressure problems on the arterial side. Now, there are advantages from a physiologic standpoint of using the VV segment, the place where you put both cannulas in the venous side, because you don't push the blood opposite up against the heart. So if you put a cannula in on the arterial side, you're actually pushing blood the opposite direction up the aorta against the heart. So in general, if you only have a respiratory problem, then we try and do it just on the venous side. If you have a respiratory and a perfusion problem, then we try and do it on both the venous and arterial side. So that is ECMO. Now we start talking about resuscitative ECMO. And resuscitative ECMO is how we define it, and particularly for the book, we define it as something that needs to be done right now. So you can't call people in. You can't have people coming in from home to do this. And so that would include a couple of different things. The first thing would be the severe respiratory person. So if you look back through history, a lot of ECMO was done on ARDS. And particularly through COVID, it's probably how many people know it, is that ECMO was done for a lot of COVID patients. So this is not an emergent setting. This is, you make the decision after you've seen this patient fail on their ventilator for a day, a couple of days, maybe longer. Resuscitative ECMO is when you can't have it, when you don't have time for that. So the respiratory problems that would be included in the resuscitative ECMO component would be anaphylaxis. Someone's about to die because they're allergic to peanuts, or someone who has a really bad asthmatic flare. These are things that, I mean, no one should ever die because we can't ventilate them, right? If you can put a couple cannulas in and you can use a machine to augment their ventilation, augment their oxygenation, no asthmatic should die in the first hour, and no anaphylactic patient should ever die. So these are two patients that young, healthy, otherwise doing great patients that you can have just a clean save with the use of a couple cannulas. So that's the resuscitative VV ECMO. When we talk about resuscitative VA ECMO, veno-arterial ECMO, that's when you get into the component of ECPR. So they could be in severe cardiogenic shock. They still have a pulse. You put in some cannulas, great. But the term ECPR means ECMO in cardiac arrest. And that's the particular component that we're probably focusing most of this talk on here. So resuscitative ECMO, or ECMO on the VA side, ECPR, is the most difficult way to do this and has the highest risk of complication because you're trying to do this under chest compressions. So resuscitative ECPR involves having them doing manual chest compressions or mechanical chest compressions while you're putting in these cannulas in the emergent setting.
And of course, the patient is like thin, perfect vasculature, not moving at all, just like total cinch, no problem.
Yeah, so there are multiple layers of complexity in this. One is the skill set to get these cannulas in. Two is the organizational aspect to run a resuscitation extrinsic to the ECMO, right? So one of the things you want to make sure that you do in this is not decrease your survival rate because you didn't focus on the traditional ACLS measures. Now, honestly, the truth is that you're going to find that you have more ACLS saves extrinsic to the ECMO. And that's what we found. This is all over the world. We find this. And if you look at one of the recent randomized controlled trials, you found this in grand effect. They started measuring, traditional ACLS outcomes, and so many more people survived simply because we cared. not because of the ECMO. It's because we cared.
But
We ran the resuscitation well. We focused on all these things. We didn't have the nihilistic approach that was mentioned earlier about, I think in the previous segment, about how you would look at cardiac arrest that come into the ER. So you're going to have.
But part of that is just the sheer, and you mentioned this in the previous podcast. The idea of having an art line in the middle of CPR is really revolutionary to telling you how effective your CPR is. Because we've determined, as you know, a slight movement up, down, right, left, the placement of the hands changes cardiac output during CPR. And prior to having an art line, we were just guessing or trying to feel, I've got a pulse, that's a strong pulse, come on. And you stick an art line in that, and you could actually see the numbers go up and go down by the placement of the hands or the machine or whatever. So I'm not disagreeing with you. Carrying is important, but hand placement is really important. You can measure cardiac output in hand placement.
Yep. I mean, those things are all included in that. And that once you start measuring these things, once you start really focusing in on things, all types of things improve. So we have organizational aspect, we have procedural aspects, and all of these things are important for the general outcome of the patient. And then I think the third component here is then the physiologic management of the patient after you start ECMO, after you begin the resuscitation. You need to understand that component.
So Zach, that kind of leads us into a great next question, because there's, as you are I'm sure are used to, there's plenty of naysayers out there who are always saying, oh, it's going to be too complicated, too expensive, we don't have time, all these things. What do you feel like from an evidentiary or literature perspective at this point? Where do you feel like ECPR is? Is this something that there's still equipoise? Are we sure it works? How much does it work? What's your take on the literature at this point? We don't have to get into like the details and methodology of specific studies per se, but just kind of, I know you've spent so much time reading probably every single ECPR and ECMO article that comes out these days. What's your kind of overview of what the literature is telling us about the efficacy here?
Yeah, so I think ECMO is a great topic to allow you to understand the benefits and downfalls of research, the downfalls of observational studies, the downfalls of case series. Like if we go through all the case series in ECMO, it looks like it's phenomenal. You go through some of the observational studies and maybe you can find great evidence and poor evidence. So there's definitely benefit to randomized controlled trials, but even randomized controlled trials have their downsides. So when we put all that evidence together for ECMO, I think what we see is a procedure that is very good. It is very good at improving the survival of out-of-hospital cardiac arrests. It's very good at improving the survival of in-hospital cardiac arrests. It has some logistical issues. These logistical issues involve EMS, they involve organizational of the system, they involve timing of placement, they include inclusion criteria, and all of these things are going to change the overall outcome survival rate from institutions that try and do ECPR. When we see this done in the ideal setting, the outcomes are outrageous. They're just phenomenal. I mean, Minneapolis, you look at their survival of 45%. You look at if they get the patient in less than 30 minutes, 100% of their patients walk out of the hospital. That's just crazy. That is crazy numbers. That is numbers that we would have pronounced all of those patients 10 years ago. And they're having 100% walkout. Now, even Jason agrees that number is not realistic. Like it will go down. But this is not a small number of patients. They have been publishing on this for years now and have shown that if you get to their shop fast, they get you on the pump, you meet the inclusion criteria that says your brain's still awake and your heart's still viable, they get you out of the hospital. So I think you have to look at each study and be honest about the benefits and the downsides. I think a great paper to look at to say, hey, we got to be careful about this is the Oslo paper. put a lot of work into making this ECMO program, and ultimately the outcomes were not better. And that's primarily because they couldn't get patients on the pump. They couldn't get to them fast enough. They didn't have a well-organized system, and that's not because of lack of energy. It's just there are logistical issues. I will fully acknowledge that in San Diego, we have all kinds of logistical issues that I am jealous of what Minneapolis has set up. I'm jealous of some of the other great places in the world that have set this up, because I've not been fully successful in trying to integrate this into our system. We have some promising things that are coming up.
Logistical issues like what? Traffic, skill level. What are these logistical issues that you're talking about?
Well, there are many questions here. One of the questions would be who should cannulate? Should ER docs cannulate? Should CT surgeons cannulate? Should cardiologists cannulate? That would be one question that Minneapolis would say, if you looked at just their data, maybe cardiologists should cannulate. However, you're not going to have Jason Bardos and Yiannopoulos. Those guys are 1 in a billion. So
because of their dedication to it and their availability.
Yeah. And so if you really want to maximize the number of survivors, then I would argue that emergency physicians are the way to go.
Yeah.
So in San Diego, we have problems with trying to coordinate patient delivery to hospitals in a timely fashion. And that actually is not even in Minneapolis, they struggle with this. They have a hospital that's a mile away from them that diverts cardiac arrest to their hospital. So that's a logistical problem everywhere. Some places like Albuquerque, they do it phenomenally. They control their EMS, and they can maximize the survival of their out-of-hospital cardiac arrest simply by managing where they go.
Yeah. Are you guys working in San Diego? Is there a board? Is there a committee that is working with your pre-hospital teams?
Well, one of the things that we've done in San Diego is we've trained the other hospitals. So we trained our crosstown kind of rival, and they took off. They took off and they flew, and they've had some great outcomes with their patients. And then just 9 months ago, we trained our sister hospital here in San Diego, thinking that this would not be the same as how we had trained this other hospital because of resource allocation and all kinds of things. And it turns out, great to our surprise, they are phenomenal as well. They're doing a great job. So now how do we incorporate these entities in San Diego in a coordinated fashion so that EMS can deliver the right patient to the right hospital at the right time?
And are each of those three hospitals, are they all places where they can get cannulated, get on pump, and then stay at that hospital? Or is it more a hub and spoke where they're going to get cannulated outside, get stabilized, maybe plus minus go to the cath lab, and then get transported to you guys?
Great question. And each city is different in that regard. Sure. In San Diego, these three hospitals will be able to manage the patients.
Okay. That's great. It's very generous of you. I know that I've talked to certain people where once one hospital in an area gets it, there's a little bit of a competition, some rivalry going on because everybody needs numbers. If you're maintain skill sets, we'll probably talk about economics another segment, but that's exciting that you guys were able to get everybody on board, kind of delivering the best possible care. Because it seems like the future here is in the same way we've got trauma centers, the same way we got stroke centers. Like we're going to have designated certifications for hospitals for ECMO and ECPR. I mean, it seems like that's where things are headed. I mean, is that what you're seeing? Do you think things are going to be headed that way in the future?
It's a great question, and I don't know the answer. And I also don't know what is optimal. I believe that the inclusion criteria we currently utilize throughout the world, which is there's slight variations. Well, I guess there's pretty big variations. But these inclusion criteria represent a tip of the iceberg, like we said before. This is not everyone that would benefit from ECMO. And so in that regard, if you have only a few centers doing it in a given city, you're going to have some patients that would have benefited from going to a smaller hospital that could put them on the pump more quickly and then transfer them. So how do you decide that? Well, each city is going to be different. And like Mark just mentioned, traffic is actually a big deal. Why does New York City not have great outcomes? Because you can't get to the patient. You can't get them to the hospital. So these geographic constraints are a real issue as well. If you look at what the Netherlands is doing with pre-hospital, just flying helicopters all over the country to pick up these patients, that might be the next level. Each place is going to have their own way to maximize survivorship. And I hope that these conversations will become more front and center, but I hope that they're successful in actually optimizing what their city should do.
I want to jump in and actually ask a question that's back down to the level of the basics here, and that is the actual cannulation. Is this a skill that you think that literally every emergency physician could become good at?
Well, I think the bigger question here is, where is our specialty going? Right? That is the question. What are we becoming? And in a day and age where urgent cares are actually utilizing, like they're a significant component of our healthcare in a good way. They are improving patient access in many ways. And so what is the emergency room, and what makes us specialists in emergency medicine? And I would argue that one of the future, if not current, ways that we are specialists is that we develop an endovascular skill set, is that we develop it not only for this ECMO technology, but for all kinds of other things that could be done in the ER. Many technologies fail, not because the idea isn't a great idea, but because physicians can't actually do it. And that's kind of a sad thing. So if, as emergency physicians, do I think that we should prioritize in our training an endovascular skill set as a component of their competency? Absolutely. Absolutely. Do I think that older docs who haven't done lines in a long time should try and get better at that? Yes, I do think they should. Understanding that we all are going to, even myself, as I go through my career, there are going to be things, and this happens all the time with our new docs. They show me something, I'm like, oh man, I didn't know that. So we're going to have that go through our career, but I think that endovascular mindset is something that we really need to prioritize in our emergency medicine training.
Zach, I know we've been kind of skirting around it, but I'd love just for our listeners and viewers to hear what are the kind of key components of inclusion criteria. I know that there's some big differences depending on what shop, what country, but in your view, what are kind of the highlights of most of the people that are getting put on ECMO and cardiac arrest?
Okay, so the main things are witnessed bystander CPR. So if it was an unwitnessed arrest and there was no bystander CPR, that's a problem. Does that actually eliminate the patients? No, it doesn't. It doesn't eliminate them. It doesn't make their survival zero. So what we are talking about in inclusion criteria is actually an economic decision. And I know people hate to hear that, but that's what it is. It's an economic decision, meaning that at this stage, we are not able to put every asystolic arrest on ECMO. Just not possible. And so is there an asystolic arrest that's going to survive with ECMO? Yeah, there probably is. In fact, we've had some. We've also just recently had a patient that was far outside of the lactate pH inclusion criteria, which we'll get to in a second. And their brain seems to have been fine. So these are things that are not 100%. They are relative things. They were talking about the chance of this person surviving. And that's a negative aspect. So bystander CPR, witnessed arrest, VF, VT is better than PEA as far as survivorship, and PEA is better than asystole. Okay, so if you wanted to start your program off initially, probably VF, VT as an initial rhythm is a good way to start.
What about age? What about age? Do you do this in pediatric cases?
So interestingly enough, I work at a shop where we do not take ambulance traffic from kids. So our chance of getting a pediatric arrest would be very small. I think it would be very unlikely that we would put a pediatric patient on ECMO. However, we are right next door to Rady Children's, and we've actually developed a whole thing where both of us are symbiotic in trying to help each other out if we did have a case of an adult going to their hospital or a pediatric going to our hospital.
Yeah, I'm just familiar with cold water drownings and hypothermic pediatric patients, and I have to say that that's probably one of the most frustrating cases of my professional career, is watching a kid be cold doing CPR for 30 minutes, thinking surely we're going to eventually get something back out of this kid, and knowing that we're not oxygenating them well enough and wishing that we had something more to do. So that was my grandfather talking here. But I hope that we eventually would include pediatrics in some of this.
Yeah, absolutely. And it would be cannula size and being able to get the cannulas in. I mean, if we're talking about a 16-year-old, then yeah, I mean, we should be able to do just fine. We're talking about a 2-year-old. Okay, now you got to have the smaller cannulas, and you will have to have a different skill set for that.
Yeah.
Okay, so inclusion criteria: bystander CPR witnessed, VFVT, age. As far as the older age, has not borne out as well in the literature as far as a strict age inclusion criteria, although many people use around 70, 75. Some people use a lot less. The Netherlands are using really low age cutoff criteria for them. And then time to ECMO initiation. So the shorter, the better. And oftentimes it's around 60 minutes is what we're talking about as our cutoff time.
And that's, just so it's clear for everybody, that's considered total time down. So not necessarily no flow versus low flow. That's entirety of duration.
So low flow, meaning they're getting chest compressions. That term is sometimes confusing. No flow, meaning they're not getting any chest compressions and they're in cardiac arrest. This is low flow time of 60 minutes. Hopefully they have minimal no flow time. That's what we're talking about. Bystander CPR being as one of the inclusion criteria. A couple other things that are important to mention. Lactate is one of the things that Minneapolis uses. They don't actually use witnessed arrest because they use VF-VT as their initial rhythm. And so if it's unwitnessed, but it's VF, then we know they haven't been down that long. But they use this lactate, 16, 17 is kind of the general area where people start saying, okay, that's too high. pH 6.9, 6.8 is where we start saying, okay, maybe that's too low. But again, these are arbitrary cutoffs, and there are survivors that go lower than that as far as pH, and higher than that as far as goes for lactate. The last thing that Paris is kind of made popular is the idea that if they are neurologically intact during CPR, so if they're grabbing the ET tube as you're doing chest compressions, then that would be something that you would then kind of push them into the inclusion criteria.
And that's what they call, signs of life, various forms of signs of life.
And they go as far as saying pupillary constriction as being one of those. This is, these are things that they do have a advantageous prognostic value.
Very cool. So ECPR, resuscitative ECMO, and ECPR is really, you would consider that a subset of resuscitative ECMO, right? Because resuscitative ECMO, we're looking at emergent need for ECMO, but various indications. ECPR specifically in the cardiac arrest category. We talked about VV, VA ECMO. So VA, we're taking care of replacing really the lungs and the heart in the sense of oxygenation, ventilation, and perfusion. We talked about inclusion criteria. We talked about some of the logistics and barriers to really getting the whole project and the whole process done in the emergency department. We're going to do another segment where we definitely want to dive down a little bit more into the weeds, if you will, about some of the logistics of how do you actually make this happen in the weeds of in the day-to-day in the ER, step by step, if that's good. Any other questions, Mark? I know we're getting close to the end here.
Yeah, we are. I just want to say to our viewers and listeners, if there's one thing that should have poked you in the ear, is that there are shops, particularly the gold standard being Minnesota. There are shops where if you get there alive, you're going to walk out alive, and that is unheard of. It's absolutely unheard of. Obviously, even you guys are not there yet, but the point of it is that is the possibility that if we raise the technical capabilities, the logistical capabilities of hospitals, not university hospitals, but community hospitals, everybody, we have the ability to actually have a new impact on the patients that need us most, and that we are in the position of helping the most. It's one thing to have a cardiac surgeon or a cardiologist, but who's there ready 24/7? It's us. Okay, so it behooves us to get the skill and the knowledge and to actually pick this responsibility up, learn this skill, learn about it, and promote it, because I think that it has the possibility of really being a real reason for a shift in what we do as emergency physicians. We've sort of gotten ourselves into the idea of being diagnosticians and being the front door to the hospital. Okay. But I don't know about you. I came into emergency medicine 40 plus years ago to save lives, Okay. And I think that this is an opportunity for emergency physicians to actually play that role again. And so I hope, as a viewer or listener, I hope you've caught the gist that I'm kind of high on this idea. and I think that this is something that we need to hear more about, think about, get the book, figure out what's going on with this. There you go. Get the book, consume that, and see if this is something that you think that you and your shop could do, because I think it's something that needs to spread out across the country. So thank you for joining EP Talk today. Zack's coming back for another installment, and I hope many more after that. But thank you for listening to us today, and we'll catch you next time. Thank you.